Welcome to this episode 22. I will be giving introduction in this. I will share my presentation. Is it visible?
Yes. You have to start the presentation.
I'm
So your desktop is visible, not
not.
the.
I'm not able to see. Stop share. No, I am not able to see.
So PPT is not visible. The desktop is visible.
Yes, it is visible now. Make it slideshow.
Good evening, my dear colleagues. I, Dr. Anil Shah. Good evening, my dear colleagues. I, Dr. Anil Shah, President for Maharashtra Chapter, welcome all of you to this wonderful series webinar that is A to Z of manual small incision cataract surgery. Today is episode 22 and the title for today's episode is Mastering the Storm, Managing Complications in SICS. The aim of SICS webinar is to popularize SICS by series of webinars to enrich our knowledge, to emphasize how SICS is safe, cost-effective with minimum learning curve, to emphasize its usefulness for community basis, to involve expert surgeons to share their knowledge and experience, and to make SICS interesting and a popular technique. Here are few important quotes. You don't truly master SICS until you have mastered its storm. Every complication is a lesson. Every recovery is a trump. Complication doesn't define surgeon. How we manage them is very important. In surgery, as in life, mystery isn't avoiding the storm, but in learning to navigate it with the skill, patience, and courage. This slide demonstrates various types of complications that can occur during small incision cataract surgery. Intraoperative complications can occur during tunnel construction. Anterior incision causes poor self-sealing effect, wound leak. Wide tunnel causes risk of bleeding, risk of premature entry, difficulty in nucleus delivery. Incision length causes short incision, difficulty in nucleus delivery, endothelial damage, and iris damage. Long incision causes poor approximation induced against the astigmatism. Incision depth leads to premature entry, buttonholing, and scleral disinsertion. Descendant membrane stripping can occur when main wound instruments are used and when there is a paracentesis also. Capsulotomy and capsular excision produces a peripheral extension, rexis run away, and posterior capsule tear. During hydro dissection, incomplete hydro, forceful hydro, posterior polar cataract complication, inadequate capsular back separation, fluid misdirection syndrome, zonular damage, posterior capsular tear, nucleus drop, capsular block syndrome. During nucleus prolapse, incomplete hydro procedure, small rexis, mild iris synechia, very soft nucleus, hard brown nucleus in small people. During nucleus delivery, endothelial damage, zonular dialysis, PCR, and iris sandwich. Iris injury can occur, causing sphincter tear, iridodialysis, and iris prolapse. Hyphema can occur from tunnel, from posterior tunnel, deep tunnel, from iris root, iris handling, and iridodialysis. Intraoperative myosis can occur. Zonular dialysis can occur due to pre and intraoperative phaco sandwich technique. Posterior capsular tear and drop nucleus can occur, and very rare complication as expulsive hemorrhage can occur. Immediate post-operative complications are wound complications in which wound adhesions, nucleus and cortical fragments in the tunnel, corneal complications like corneal edema, striate keratitis, bullous keratopathy, post-operative iritis where excessive manipulation during nucleus prolapse and nucleus delivery or residual cortex, and post-operative rise in intraocular pressure due to retained viscoelastic and overdistance of the anterior chamber while reforming. Late complications are corneal complications, uveitis, capsular back complications, PCO, IOL malformation, CME and ophthalmitis, and posterior segment complications are retinal detachment, lens loss syndrome, vitreous hemorrhage, and vitritis. Successful management of the complication depends upon early recognition, knowledge, skill and judgment of the surgeon. And for this we have Chairperson Dr. Prakash Marathe, Dr. D.K. Shakya, and the speakers who are expert in their field with the best of their knowledge and experience. We have Dr. Mihir Paranspe, Dr. Sonali Jadhav, Dr. Sunil Thangraj, and Dr. Deepak Megur. And the discussant who will discuss and argue and debate this webinar, Dr. Manish Bapai, Dr. Ranjit Singh Dadiwal, and Dr. Deepak Mishra. And the moderator who will preside over the webinar, making a discussion enjoyable and effective, we have Dr. Ruchita Machwe and Dr. Pankaj Shah. I am really very much thankful to all the colleagues, chairperson, speaker, discussant, moderators, and the team of Entor for sparing their valuable time and making this webinar a grand success. Thank you once again. I'll hand over to Ruchita, madam.
Thank you, sir. Hello, everybody. I'm Dr. Ruchita Machwe, Executive Committee Member of ISM SICS Maharashtra Chapter, and I welcome you all for this 22nd episode of our web series, MSICS A to Z. So before we proceed, I request the office bearers to say a few words of wisdom. Dr. Prakash Marathe, sir, who's the
Hello,
chairman
good
of
evening.
ISMICS Maharashtra Chapter.
Hello, good evening, everyone. On behalf of Maharashtra chapter of ISM SICS, I welcome all the speakers, chairpersons, discussants, and all the delegates. I think this is the wonderful webinar series by Maharashtra chapter. I think it's more than 2 years now. And most of you must have attended this. It is from basic to all things which are covered in the syllabus of SICS. And most of the people feel that SICS is very simple surgery. It is not at all difficult. And then when they land into complications, probably they do not know how to come out of it. So this particular webinar connects with the complications. And whenever there are complications, you should be able to tackle them. Even in PHECO, if you are in complication mode, probably you should be able to convert that from PHECO to SICS. So to manage the complications is not very easy. It is more difficult than doing SICS. So tackle this particular topic, Dr. Anish has designed this webinar in the perfect manner. So there are talented speakers, chairpersons, and discussants, and everyone definitely will enjoy this particular webinar, and it will be beneficial for all the delegates and each and everyone. Over to you, Dr.
Thank you, sir.
Thank you.
May I now call upon Dr. Mandar Paranspe, who is the Vice President, Maharashtra Chapter, ISMICS. Dr. Mandar, sir. Okay. I'll call upon Dr. Anand Pangarkar, sir.
I'm sorry, I heard you a little late.
Okay. Yeah.
Sorry.
Welcome, sir.
Yeah. First of all, congratulations to the ISMS-ICS Maharashtra chapter for one more webinar in the series. As the saying goes, if a surgeon does not make complication or claims to never have complications, either he is not operating or is telling a lie. So we know that complications are part and parcel of any surgery, and we have to be aware of them. As far as possible, try to avoid them, but even if they occur, you should be smart enough to tackle those situations. So I'm sure that today's webinar will help in riding us through the storm. So once again, congratulations to all the speakers, and we look forward to this interesting webinar. Thank you.
Thank you, sir. May I call upon Dr. Anand Pangarkar, sir, who's Chair, Scientific Committee, Maharashtra Chapter.
Hello, Dr. Pangarkar, sir. I think there is some issue
Hello,
of
good
connectivity.
evening. Am I audible?
Yes, sir.
Yes.
Am I audible?
Yes, sir. Yes.
Good evening. Welcome to yet another episode. We have had very interesting webinars on this very important methodology of cataract surgery. As it is rightly said, surgery and complications are just the two sides of the same coin. It needs courage on the part of the speakers and the resource persons to share the complications they have encountered. Everyone of us who is a surgeon will encounter a complication sometime or later. Mastery lies in how you get out of that storm. I'm sure this will be a very interesting thing and a great learning experience for all. Welcome you all. Thank you.
Thank you, sir, for your words. So today's episode is on mastering the storm.
Dr. Rujita, let me interpret. From Central National SICS, ISM SICS, Dr. Deepak Mishra, who is the secretary, is here. I welcome Dr. Deepak Mishra and to say a few words.
Thank you, sir. As we all know that the Maharashtra chapter is doing wonderful job by educating not only the young ophthalmologists, but also the practicing and the ophthalmologists who are master in their fields. Anil Shah always prepared his webinars in such a way that we got information that everyone at the end of the webinar got something. Either they are, and today webinar is so important that even we all know that learning in surgery is just a 25%. Rest 75% is managing the complication. And the good surgeon is that who can manage his own complication and not only manage. For the lot of young ophthalmologists and other people are watching this webinar, I suggest them from our learned speaker, try to identify the early stage, means at which stage you can identify that yes, complication is going to happen in the future, and identification of complication and its management. Both is very much important, and I congratulate all the teams of the Maharashtra chapter for this webinar. I'm looking forward to learn something more after this webinar. Thank you, sir. Thank you.
Thank you, sir, for your words. May I now request my co-moderator, Dr. Pankaj Shah, to introduce today's respected chairpersons and speakers. Over to you, Dr. Pankaj.
Thank you, Dr. Rujita. Good evening, all of you. Is my screen visible?
Not yet.
No, not yet.
Again, the same story, you have to double click to enter the full screen mode. Sharing is still not same.
Not visible yet?
Yeah,
Yes.
now it is same.
I'll just try it again once.
No, it was seen now. Now it is gone again. It was there.
Yes,
Again, again try sharing your screen. It was seen actually before.
it is visible now.
Yes.
Yeah. It's visible?
Yes, yes.
Yes, visible.
So we have Dr. Prakash Marathe, Chairman, Maharashtra Chapter of ISMICS. He is a past President, Maharashtra Ophthalmological Society, Pune Ophthalmological Society, and IMA Pune. A very strong pillar of ISMICS. He was faculty at installation of Australia and New Zealand Chapter of ISMICS and has organized various conferences and has presented various papers at Kenya also. Then we have Dr. Anil Shah, who is presently the president of ISMICS Maharashtra chapter. He is a private practitioner in Nandurbar since 1986. And we all know he is very famous for his snare for MSICS, large foldable IOLs for MSICS. He has a modified intracystic implant for DCR and Best Research Private Practitioner Award. We have one more person today, Dr. Devendra Shakya. He is a professor in Department of Ophthalmology, Gajraj Medical College, Gwalior, and he has been extensively working in comprehensive ophthalmology at this place and has various awards like Times of India Lifetime Achievement Award, Extraordinary Community Eye Health Care Services for the people of Central India at AIMS Bhopal. Today's galaxy of speakers, we start with Dr. Mihir Paranjpe. He is a skilled anterior segment surgeon and including pediatric cataracts, strabismus, post-operative, and operated more than 7,500 cataract surgeries, including SICS and FECO. He has extensively worked in Arvinda Hospital in Tirunelveli, Nayantara Clinic, Mai Mangeshkar Hospital, Sanjeevan Hospital, and lot of community work through MG Achawal Charitable Trust, Pune, and Vanvasi Kalyan Ashram. Another speaker, Dr. Sonali Jadhav, she's consultant at Gokte Eye Clinic. She has done her MBBS from Mumbai and MS from Yavatmal, fellowship in cornea and ocular surface HV Desai Hospital. Dr. Sunil Thangaraj is a comprehensive ophthalmologist, medical superintendent, OEU Lions Hospital, Sri Ramnagar, Andhra Pradesh. I welcome you all of you, and I hand over the mic again to my co-moderator, Dr. Rujuta. Thank you.
Thank you, Dr. Pankaj. As we all know that discussions play a very vital role in any webinar. Any presentation without discussion is far from fruitful. So let me introduce our discussions for today. Dr. Manish Bapai is a cataract, refractive and VR surgeon at Dr. Bapai Hospital, Nashik since 2005. He has done VR fellowship from Sankara Nitralaya and was a gold medalist and best outgoing DNB student. He is known for his innovations like the Claw, a novel intraocular foreign body forceps, and aspiration scraping. He has received awards for these two innovations. Our second discussant is Dr. Ranjit Singh Dhaliwal. He is a consultant anterior segment surgeon at Eye Infirmary Nabha. He is a web editor of ismsics.com. He is a contributing author to 10 books and master's guide of manual SICS. He has got over more than 80 publications, presentations, instruction courses, CMEs, workshops to his credit. He is on the editorial board of Global Journal of Cataract Surgery and Research in Ophthalmology. So we are honored to have you here. Our third discussant is Professor Dr. Deepak Mishra. He is Honorary Secretary ISMSICS. He works at Regional Institute of Ophthalmology, Institute of Medical Sciences, Banaras Hindu University in Varanasi, UP. He is a council member of South Asian Academy of Ophthalmology. He is a member ARC AIOS. He is founder of PG Examination Forum. A warm welcome to you, sir. Without further ado, may I invite the speakers for their eagerly awaited presentations. Our first speaker is Dr. Mihir Paranspe. He will be delivering his presentation on pre-operative risk and planning. Over to you, Dr. Mihir.
Thank you, madam. Is my screen visible?
Not yet.
Not visible.
How about now?
Yes.
Yes.
Is the slideshow visible?
Yes, yes.
Good evening, everybody. I thank Dr. Parikshit Gokte sir for this opportunity. Coming to the topic, every cataract surgeon aims for complication-less cataract surgery, and they want to give their patients a good visual outcome. But to achieve that, we have to know which eyes are at higher risk and which eyes can have a greater complication, and strategize every surgery, every patient's surgery accordingly. To do that, we have to have a proper systemic as well as ocular examination. In ocular examination, we have to do thorough anterior as well as posterior segment examination to rule out any pre-existing pathologies. In systemic examination, we have to see if the patient is having any cardiac anomalies or any cardiac issues, as well as diabetes mellitus, hypertension, and some specific conditions like benign prostatic hyperplasia, for which they will be taking alpha blockers, and which can cause floppy iris during cataract surgery. And every patient should get counseled of their risk factors pre-operatively. The dreaded complication of any cataract surgery is endophthalmitis. So to avoid that, we have to do proper examination like nasolacrimal duct patency to rule out their blockage, or any lead anomalies like ectropion, entropion, or trichiasis. And we have to rule out conjunctivitis as well as uveitis. And the uveitis period should be less than 2 to 3 months, where the uveitis should not be active. And to avoid endophthalmitis, we have to use povidone iodine drops preoperatively and intracameral antibiotics at the end of the surgery. Coming to the specific risk factors, we will see risk factors from anterior to posterior. Coming to the cornea, the corneal opacities can be very difficult to manage because they hamper our visualization in the anterior chamber, and thus we can have difficulty in doing rexis as well as cortex work or even placing the IOL. So this one here we can see there is a dense arcus in which it is very difficult to differentiate between the cornea and the sclera or to locate the surgical limbus. So the placing of the incision can be difficult in some cases, where the incision can be placed more anteriorly, or we can have premature entry or button holding. So we have to zoom out our microscope and look for the surgical landmarks properly, locate the limbus and place the incision. Once we place the incision, then the rest of the surgery is normal. In this denser kind of opacities, what we can use is we can use endomyelineators, which we use in VR surgery from the clear part of the cornea, so that the ocular structures can be prominent and we can visualize them properly. In some cases, there can be endothelial decompensation like Fuchs dystrophy or long-standing glaucomas. So we have to use a proper high density viscoelastics to protect the endothelium in such cases. Coming to the pupil, non-dilating pupil is the most problematic thing which we face in our day-to-day practice. So to avoid that, and these conditions can be seen in the patients like pseudoexfoliation or glaucomas, angle closure glaucomas, etc. So to avoid and to handle this problem, first what we have to do is we can use the intracameral dilating agents like phenylnephrine or diluted adrenaline, but sometimes these also can't help. So we have to opt for the mechanical things like stretch pupilloplasty or microsphincterotomies, and sometimes we have to use iris hooks as well as rings. Coming to the iris, the most common problem in iris we can see is floppy iris, which we see in cases of benign hyperplasia if the patient is on alpha blockers. So the major problem in these cases is incarceration or the iris prolapse. So more prominent the iris prolapse, and there can be inadvertent complication like iridodialysis, which can lead to poor visualization. So the rest of the surgeries can be difficult. So initially, if we recognize the problem, we can use intracameral dilating agents, and we have to use iris hooks or rings to stabilize the iris. The next iris problem is posterior synechiae, which we see in anterior segment or anterior uveitis, where there is adhesions between iris tissue and the anterior capsule. So under the cover of viscoelastic, with the help of iris repositor, we have to gently break these adhesions and can stretch the pupil later on, so the pupil will become more dilated and we can proceed with the surgery. The another thing which we can see in our day-to-day practice is iris neovascularization. This generally we see with the retinal ischemic disease like PDR and retinal venous occlusion. So first we have to treat those with PRPs and anti-VEGFs, intravitreal anti-VEGFs. This can reduce the neovascularization of the iris. These pupil can be non-mydriatic. So we have to use some dilating agents, but do not use MSTs, sphincterotomies, or stretch pupilloplasty, as these can bleed profusely in the anterior chamber. Coming to the major topic is lens-related risk factors. The first one is Morganian cataract. In this, as soon as we puncture the anterior capsule, there will be a milky fluid coming out of the back. So we can wash this milky fluid with the saline, or we can complete our rexis under the viscoelastic injection. So then the rest of the surgery can be pretty straightforward. This all we know. This is the Argentinian flag sign, which we see in intumescent cataract. Here, the intralenticular pressure is very high. So as soon as we puncture the anterior capsule, it runs away to the periphery towards the zonules. So to avoid that, what we can do is do all your manipulations at this stage through side port, and keep your AC very tight with viscoelastic, and concave. Make sure that your anterior capsule is concave. So you have to use high density viscoelastics to complete rhexis. Sometimes what we can do is we can do initial small rhexis, through which we can wash and aspirate all the liquefied cortex, and then complete the rhexis in two stages. Coming to the subluxated or dislocated cataracts, this we can see in very high mature cataracts or pseudoexfoliation or traumatic cases. Some syndromes also can be associated with this, like Marfan's syndrome or homocystinuria. Generally, syndromic patients, we can fix the capsular bag with the help of CTS segment, and can place the IOL in the bag. But in very high grade phacodonosis or more than 270 or 180 clock or zonular dialysis, in the cases like trauma or pseudoexfoliation, we cannot save such back complex. We have to remove the lens with the back in toto, and we can place or fixated IOL in same sitting or in the subsequent sitting. This is a grade 4 brown cataract. Sometimes we call it as a black cataract also. This is very notorious one. The size of this cataract is very huge. So to remove this cataract from the eye, we have to have a good 7 to 7.5 mm incision. And rhexis has to be large, because if we try to remove this nucleus from the small rhexis about 4.5 to 5 mm, then there will be adverent complications like zonular dialysis. There will be undue pressure on the back and zonular apparatus. This is a posterior polar cataract. Here we have to do very gentle hydro procedures like hydrodelineation. Do not do hydrodissection, and we have to opt for the low flow setting surgery, where the infusion pressure is a little bit on the lower side. Because more the anterior chamber pressure, this weak posterior capsule can break on itself as well. As when you're coming out of the eye, make sure that you are filling and you are maintaining your chamber properly, because from the vitreous thrust itself, the posterior capsule can break. Coming to some special cases like membranous cataract, these are all long-standing cataracts or very long, old traumatic cataracts which are ignored. In this, the cataract and the nuclear material is absorbed on its own, and there is a adhesion between anterior and posterior capsule. So it is very difficult to do capsulotomy or capsular rhexis in these cases. So we have to do capsulotomy with the help of Vanna scissors or vitrectomy. And at the same time, we can clear the visual axis from the opacities and keep enough capsular support so that we can place the iris IOL in the sulcus. Coming to the traumatic ones, these are the very notorious, and we cannot predict these cataracts properly. If there is an open globe injury, first try to seal the wounds, and after sealing the wounds with the sutures, what we can do is aspirate all the cataractous material. There can be pre-existing PC tear from the trauma, so make sure that you are having your anterior vitrectomy support or VR surgeon in your OT complex. Do not place IOL in open globe injuries, because if you place IOL in the primary surgery itself, there will be a tremendous amount of uveitis later on. Coming to special conditions like glaucoma, in long-standing glaucoma, if the patient is on AGM, there can be endothelial decompensation. So we have to opt for, we have to do surgery accordingly. The pupil can be non-dilating, so we have to use all the non-dilating pupil dilating methods. And if there is a pre-existing trap, we have to do SICS from the temporal aspect. But phaco is preferable in this condition. Other systemic conditions like diabetes, in diabetes, if there is an inadvertent PCR or PCR happens in these cases, and with vitreous loss, then the proliferation of diabetic retinopathy is very florid. Then there can be in future the patient can land up in NVG or neovascularization of iris, etc. So try to be very careful with the patients with the diabetes. In hypertension cases, we have to control the BP priorly, because if we do not do that, what happens is any fluctuation can cause some amount of bleeding from the posterior segment. Sometimes we can land up in expulsion hemorrhage as well. And the patient with asthma and COPD will have cough bouts during surgery. So we have to be very careful in such patients. So give and nebulize them before the surgery and give oxygen on the table. This is a study done on 1400 cases, 1400 eyes, in which they have divided risk factors into 3 categories and allotted them into 4 groups based on their score. So higher the group, more the risk for each patient. And I think we can use this in our day-to-day practice so that our complication rate reduces. Thank you.
Thank you, Dr. Mihir, for such an elaborate presentation. I don't think you must have even missed a single point. And it's always said that it's better to prepare and prevent than to repair and repent. Thank you so much. Now, moving on to the second speaker, we'll be taking questions after all the speakers' presentations are over. Okay, so moving on to the second speaker, may I invite Dr. Sonal Jadhav. Her topic is intraoperative complications. Over to you, Dr. Sonal.
Thank you, ma'am. Am I audible?
Yes.
Okay. Good evening, all. Respected seniors, faculty members, and my colleagues. I am Dr. Sonali Jadhav, and first of all, I would like to thank you, Dr. Anil Shah sir and Dr. Parikshit Gopte sir, for giving me this wonderful opportunity. And I am also thankful to all my teachers for guiding me in developing my surgical skills. So today I will be speaking on the topic intraoperative complications of SICS and their prevention. So topics I have covered in this presentation are complications related to anesthesia, bridal suture, tunnel making, side pod injury, and in further steps of SICS like capsulotomy, nucleus delivery, cortex wash, and IOL implantation. So coming toward the anesthetic complications, these are more common with injectable anesthesia like retrobulbar and peribulbar anesthesia. And local complications include retrobulbar hemorrhage, which is recognized by the signs proptosis, tight orbit, and ecchymosis. Globe perforation, which can be recognized by sudden hypotonia of the globe, raised intraocular pressure, chemosis, subconjunctival hemorrhage. And coming towards the systemic complications, most common is adverse reaction to the drugs, oculocardiac reflex, and even respiratory distress can occur in some rare cases. So how to prevent it? You have to use correct technique and avoid multiple attempts. Avoid deep insertion, especially in myopes, and use appropriate volume and digital pressure to distribute anesthetic given evenly in throughout the orbital area. And to avoid systemic complications, you have to monitor patient with pulse oximetry and aspirate before injecting to avoid intravascular injection. Next is wound-related complication. So these are parameters for ideal tunnel construction, in which side should be 2 mm from the limbus downwards, and ideal depth should be 1/3 to half thickness of the sclera. Length should be 5 to 6 mm, and in case of hard cataracts, it can be increased up to 7 to 8 mm. And width of the tunnel should be 4 mm. That is 2 mm in the cornea and 2 mm below the limbus. So when there is superficial incision, it can cause buttonholing of scleral flap. and it can be caused due to shallow dissection after and uneven scleral tunnel. So to prevent it, you have to ensure that adequate depth of scleral incision is done, and you have to dissect uniformly. And while dissecting, you should follow the contour of the globe, as sclera is flat and cornea is deep. When incision is deep, premature injury can occur, and complications like iris prolapse and wound leak can occur. So to prevent it, you have to use good magnification. You should ensure that there is good magnification of microscope, and tip of the crescent should be just visible while making the tunnel. Next complication is scleral disinsertion. It can caused by full thickness cut in the scleral tissue and underlying choroid tissue is seen. To prevent it, you should make the incision in soft globe only, and should avoid filling the anterior chamber with viscoelastic, and so avoid tight globe. Make partial thickness groove, and beginners can use guarded thickness blade also. Next complication is iris prolapse, and it can be caused by premature entry, large tunnel, and increase in intraocular pressure. To prevent it, you have to maintain proper chamber stability, adequate tunnel length, and correct entry point inside the cornea. Next complication is decimate membrane detachment. It can be caused by forceful injury and blunt instruments like keratom while making the entry in the anterior chamber. To prevent it, ensure that your instruments are good and keratom is sharp, and your all the maneuvers should be done gently, and tunnel construction should be done properly. Next complex are related to anterior capsulotomy. When capsulotomy is too small, it can cause difficulty in nucleus delivery, can cause posterior capsular rupture, zonular dialysis, or nucleus drop. And when it is too big, it can cause IOL decentration. When there is runaway rhexis, peripheral extension of rhexis can cause zonular stretching and also can cause posterior capsular rupture. When there is intumescent cataract, Argentinian plaque sign can occur. And to prevent it, you have to stabilize the anterior chamber with viscoelastic and relieve intracapsular pressure by aspirating liquefied cortical material. And you should use highly cohesive viscoelastic agent to maintain chamber depth. Next, complications during hydro procedures. These are inadequate capsular bag separation, fluid misdirection, zonular damage, posterior capsular tear, and most dreaded complication can be nucleus drop too. So to prevent this, you have to avoid incomplete hydrodissection, avoid forceful any maneuvers, and in case of posterior polar cataract, only hydrodelineation should be done. These images show hydrodissection and hydrodelineation techniques of hydro procedure. In hydrodissection, separation is done between the capsule and the cortex, and hydrodelineation, nucleus is separated from the epinucleus. Next, coming to the next complication is complications during nucleus delivery. So first complication is iridodialysis. If iris gets sandwiched between the vectis and the nucleus while nucleus delivery, as shown in this diagram, it can get adversely stretched and can lead to iridodialysis. So to prevent it, you ensure that nucleus is completely in the anterior chamber, and tip of the vectis should be visible below the nucleus, and it should not be under the iris. So nucleus drop is the most dreadful complication feared by all the surgeons. It can be caused due to posterior capsular rupture with nucleus pressure. And to prevent it, you should avoid any forceful nucleus delivery. And if any posterior capsular rupture is noted, you have to seal it immediately with viscoelastic injection. So further drop of the nucleus particles can be avoided. Next, zonular dialysis. Excessive nucleus manipulation can cause stretching of the zonular and causing their dehiscence. So to prevent it, you have to be very gentle during all the maneuvers, use proper instruments, and these weak zonules can occur pre-op also. You have to be very vigilant before starting the surgery. Complications during cortical aspiration. These are posterior capsular tear, retained lens matter, and which can later lead to the uveitis, secondary glaucoma, and cystoid macular edema, and even posterior capsular opacification in the later date. Next is posterior capsular rupture. It can, this is the most common complications caused by new beginner surgeons. It can be caused at the steps of due to inappropriate hydroresection, rough nucleus delivery, cortex wash, and during IOL implantation also. So to prevent it, you should be gentle while doing hydroresection procedure and avoid any downward pressure on the posterior capsule. Use viscoelastic to cushion capsule, and you should maintain chamber stability in all the steps of the cataract surgery, and especially doing cortex wash. So next complication can be shallow anterior chamber. It can be occur throughout the surgery, and their reasons can be pre-operative tense eyeball, stout wire speculum, wound leak, improper fluid irrigation, uncooperative patient, weaning block effect, and rare is suprachoroidal hemorrhage. So to prevent it, you have to give sufficient digital pressure after giving periverbal anesthesia. Speculum should not be tight and it should not press the globe. And while doing the surgery, sometimes fluid gets accumulated the drainage bag and it gets filled. So it should be properly supported to avoid any stretching of the eyeball. Bottle height should be good, and there should not be any kinking of the tubes. And your proper wound construction is needed to avoid any leakage. Next is complications related to intraocular lens. These are optic capture. It occurs when part of intraocular lens or whole intraocular lens moves anterior to iris surface and get entrapped in pupil. It can lead to uveitis and pigment dispersion in later date. Next complication can be malpositions of intraocular lenses. When intraocular lens gets shifted to upwards or downwards, it can give to sunset syndrome and sunrise syndrome. In cases of posterior capsular rupture, there can be posterior dislocation of IOL. So to prevent it, you have to check for any zonular weakness, and if they are in posterior capsular tear, its extent should be measured, and you have to take decision whether IOL should be put or not in the posterior in the back, and IOL placement in the back should be proper. Next complication is suprachoroidal hemorrhage. It can be caused due to sudden decompression of high pressure eye. Its symptoms are sudden iris prolapse, flat anterior chamber, excessive bleeding from suprachoroidal space from posterior ciliary vessels, fundus globe becomes dull, and expulsion of intraocular structures like lens and vitreous can occur. So to prevent it, you have to control intraocular pressure preoperatively. You should avoid excessive ocular compression, and surgical techniques should be gentle. So complications in any case should not be feared, but taken and as a challenge, as it can occur in the best of hands too. And once a complication has occurred, you do not panic, take deep breath, and then proceed calmly. A good surgeon is defined not merely by skill, but by the ability to manage complications effectively as they are bound to happen. Thank you.
Thank you, Dr. Sonal, for your wonderful presentation. When you think beforehand about all the complications, you win half of the battle. And so we should always keep in mind about all the complications. Moving on to our third speaker, may I request Dr. Sunil Thangaraja to present his presentation on management of complications in SICS. Welcome, sir.
Hello, everybody. This is by no means going to be a comprehensive discourse on the entire intraocular complications. I'm going to concentrate on what you really actually commonly see, mainly concentrating on wound complications and other common complications. There are some complications being handled by Deepak. So with this, I will start. This is a movie, so I can actually keep my mouth shut for the rest of the talk, and you can go ahead with I'll just share my screen. Good evening to everybody. At the outset, let me thank the ISM SICS for inviting me for this talk, and I especially want to thank Dr. Anil Shah, who is such a passionate person about educating people and propagating SICS. I've been watching him. Thank you so much for inviting me, Dr. Anil, for this webinar. And without more ado, I'll go ahead with my talk, and I'll be talking on management of intraoperative complications in SICS. The most important complications are wound complications, and I will concentrate a bit more on that, maybe touch upon the others. And the wound complications are the most common, the most difficult to handle, and it gives a lot of loss of confidence to the beginning surgeon. And they really need to learn to rectify these complications, but very easy to say that is an even bigger learning curve. However, I will try to simplify it as much as possible. Now, going into wound complications, I have divided it into superficial dissection. You can do a deeper dissection. You can have a combination of both, not too rare, unfortunately. You can get a short wound much like an ECC, or you can put the wound very posterior, and sometimes you can just not make out your wound, and I would call it an ugly wound. Now first, the superficial wound. What are the telltale signs? When you see tissue bunching up in front of your crescent blade, you are superficial. And when you see the crescent blade very clearly, or even if you buttonhole, obviously you're superficial. Okay, and what are the corrective measures? You got to assess the wound very carefully, and it is relatively easy to correct. You can just dissect out a plane below this superficial plane. You have enough tissue, you don't have to worry about it. And I'm showing you some examples. Now this is a superficial flap, so I'm just deepening the original incision, not going right into the anterior chamber, deepening it, and then I dissect out a plane under that superficial flap. Remember, this is a different plane. These are two different planes. Okay, once I get that plane, be very careful, go only in that plane, complete your surgery much like a regular SICS, and you will have no problem, believe me. And this is again in a transconjunctival SICS. Here I am deepening the incision, and again within that deeper plane I am dissecting out a deeper plane below the superficial flap, as you can see here. Okay, with the transconjunctival SICS, little more difficult because your assistant has to keep on flushing this area of the blood so that you can have a better view. And what about the deeper dissections? If your crescent blade is very much obscured, if there is aqueous gush, if there is a uveal tissue show, or a frank prolapse or an AC collapse, these are all signs of a deep dissection. What do you do about it? Now it depends on whether you have entered into the AC or not entered into the AC. If you have not entered into the AC, you can still dissect the superficial flap from the superior flap that you have, the thick superficial flap that you have dissected out. A bit confusing, but bear with me. Okay, if you however, if you have entered into the anterior chamber, you got to see whether you have entered, very minimally, or there is a major entry into the anterior chamber. If it is a minimal entry, you treat it much like as if you have not entered. Dissect out a superficial flap and go ahead. If, however, the entry is very large, you need to suture and go to a different site or a different strategy, which I will come to later. This is one example. See here. There is a deep entry here, but it's only a uveal show. I am dissecting out a superficial flap from this thick tissue that is above. Now you have to be very careful. This is not easy to do. Okay, So you have to be very careful. Do not go too deep, do not go too superficial. But once you get the right plane, you can complete the surgery. This is again in a transconjunctival SICS. There is a uveal show, but I have not entered into the anterior chamber. And I am dissecting out a superficial flap now. Take a superficial flap. I am not going too deep, not going too superficial. Go ahead, complete my surgery, and all's good here. What happens when you have an entry into the chamber? Now here you can see the aqueous has come out and there's a collapse of the chamber, and here you can see the uvea. Even then, these are not entered too much, so you can still do a superficial flap. You may have to suture at the end. However, if you have such a huge entry, please just open up, make it like an ECC, complete your surgery. It is a bit difficult. Ignore that iris, finish your surgery very carefully, meticulously, and suture up this wound. Okay, you don't have to change your site. If it's very uncomfortable for you, close it up, go to another site and do and continue with your surgery. Now look here, this is also a large entry. You can see the uvea coming out. What I do here is I just close up this wound and convert it into a phaco. I've gone in through a clear corneal incision. So this is a little, some people ask, "Arey, tu ulta kar raha hai. How can you do this?" No, you can do this. You can use phaco to bail you out of a failed SICS. Nothing wrong in it, as long as you complete the surgery successfully. And sometimes this is very rare, you tend to put the wound so posteriorly that the tunnel becomes so large that intra-tunnel maneuvers become very difficult. So what I do is just go to the edge of that, cut the flap and shift the posterior part of the incision anteriorly. See how it is, just shifted anterior. So your cord length, your width of this incision becomes smaller and it becomes like a regular SICS. You don't even have to suture this scleral flap at the end of surgery. Now this is a case referred by a colleague. He attempted SICS. Now whenever you get cases like this, please open up the wound, examine the wound. Now you can see he's in fact cut the sclera. There is a scleral tissue. Luckily it's not lost. In fact, he has cut the iris also. This is hanging by a sliver of tissue. So I just push it in, put in a butterfly suture, close up this incision and convert it to a phaco. This is the best alternative, I'm telling you. You can also go to the temporal side and do another SICS. That is going to be a mess. So just convert it to a phaco if you're confident of your phaco skills. And all's well that ends well. And continuing with the intraoperative complications, sometimes you get these very fibrotic capsules which you cannot do a rhexis in. Now try to skirt around that fibrotic area and make a large rhexis. In SICS, you always err on a large rhexis because you do not want it to become an intracapsular surgery. Now this is a transconjunctival surgery. Now this is also a fibrotic capsule. I managed to get most of the rhexis, but this fibrotic area was impossible. So I just cut it. That's all. SICS is a very forgiving surgery. Go ahead, cut that, bring out the nucleus and carry on like a regular SICS. You can also scallop it when it's a small rhexis. Scallop that, make it a larger rhexis. Just don't do the mistake of trying to deliver this nucleus through a small rhexis, because then you will become intracapsular. And here this is an adherent leukoma with a pupillary membrane, separated the membrane, done the rhexis. Obviously the rhexis is small. So what do you do about it? Just make relaxing incisions. Don't be very worried about trying to scallop it and trying to do all sorts of maneuvers. Just relaxing incisions. Go ahead and finish your SICS. And look at this. This is transconjunctival SICS and a phacolytic glaucoma. Just look how I am putting the 12 o'clock iris hook. Okay, see, I go from the posterior part of the floor of the incision. I make a paracentesis there, put in my iris hook through there so that it goes under the floor of the tunnel. It does not come across the tunnel. Don't go through the cornea from here. Go from the posterior part, from the floor of the tunnel. Very important. Of course, I've done relaxing incisions here as well. And this is another small pupil, just to show that SICS, such a forgiving surgery. Yes, I probably have done relaxing incisions here, and through the small pupil I can easily deliver the nucleus as long as I have done an adequate rhexis. Remember, either relaxing incisions or you have to scallop that, not through a small rhexis. And this is a case multiple comorbidity. A graft is in there. Again, look at how I'm putting the 12 o'clock. This is the most important. 12 o'clock iris hook. It has to go from the posterior part through the floor of the incision, under the floor, cross to the iris. You can leave the iris hook there even during nucleus delivery and IOL placement. Don't worry, nothing is going to happen. I've taken it out in this case. Normally I don't. And this is a case of zonular dialysis, just inflating the bag and then putting in a CTR, much like what you would do in a phaco, and then you can put in your PMMA lens either in the bag or in the sulcus, depending on the clinical situation of your zonular pathology. And sometimes you do get these small pupils. I'm making relaxing incisions, and the pupil this is what happens once you deliver the nucleus out. The pupil shuts down on you, and don't go blindly. Please pull the pupil off, look where the cortex is, and see here. I'm milking the cortex out, making it peep in the pupillary area. I'll bring the cortex to the pupillary area, and then I know where the cortex is. Go under that, engage it, make sure I got only cortex, and bring it out. When you have plaques like this, you can either do it under viscoelastic or you can do it under irrigation as well. I'm using a 26 gauge needle as a cystitome, and I'm trying to bring out these plaques. I scrape off the plaques and I use my capsular rhexis, that is your micro rhexis forceps, to peel off these membranes. In very advanced cataracts like this, I would even go ahead and do these are very advanced cases. These patients don't come back, so I sometimes will even do a posterior capsulotomy. Try not to break the anti-hyaloid phase, put in the lens, and of course if you have broken the anti-hyaloid phase for whatever reason, go ahead, do the vitrectomy. Sometimes the nucleus just doesn't come out. Please don't force it out. Don't ever force it out. Check your wound first. If most probably you haven't opened up the wound, and that's exactly what has happened there. So open up the wound. Once you open up the wound, it will come out. SICS is a very delicate surgery. Don't do aggressive maneuvers in this case, in these surgeries. Thank you so much for listening to this entire discourse.
Great presentation, sir. And thanks for the visual treat of so many surgical videos. Complication is, as we all know, that complication is a part and parcel of any surgery. But who wins over it wins the race. Thank you so much, sir. Moving on to our last presentation, may I invite Dr. Deepak Meghur. He'll be talking about management of PC tear and DM detachment in manual SICS. Over to you, sir.
Thank you, Dr. Rujita. I'm audible, right?
Yes, sir.
Okay. Thank you, Dr. Anil Shah, for having me here. We appreciate your passion. It is incomparable. And thank you, the Maharashtra State ISMSICS chapter. So Dr. Sunil has covered extensively the complications. I'll be just highlighting 2 cases of posterior capsular tear and 1 case of descending detachment. And so this is a case of a posterior polar cataract wherein I'm now prolapsing the nucleus out, and let's see what happens here. That is prevention of collapsing of the antechamber. So using 2 Sinskey hooks, the nucleus is gently maneuvered out of the bag, and so far so good. There isn't any evidence of shallowing of the antechamber. Again, the chamber is inflated with OVD.
I think it is not shared. It is not
we
shared.
cannot,
We
we
cannot
cannot
see
see
the
your video.
presentation, sir.
It is not shared.
Okay, sorry.
Yes.
I think it is now okay, right?
Yes, sir.
Yes.
So using two Sinskey hooks, the nucleus is gently maneuvered out of the bag, and so far so good. There isn't any evidence of shallowing of the antechamber. Again, the chamber is inflated with OVD. Using a vector center dialer, I'm going to grasp the nucleus in between these two instruments and carefully pull it out. There is a slight shallowing of the chamber in spite of I'm using sodium hyaluronate, but at this moment there is already a tear which is visible. But at this stage, I don't think that the vitreous has prolapsed still. So I'm hoping that I can extract the cortex and place the lens without vitreous prolapse. So I carefully go in with my Simcoe cannula and then aspirated the cortex from one segment. Now, because I'm not using the traditional bimanual I&A system, which I use with my phacoemulsification, I find it very daunting to maintain the chamber. I'm unable to maintain the chamber, and as soon as I come out, there's always a collapse of chamber, and I don't have another side port through which I could have used an OVD, which I typically do with our phaco setup. There was one lack of foresight, which I should have done. So this shallowing of the chamber could have been prevented by injecting OVD from the other side port. And it looks like there are two tears. One would be the posterior capsular tear, and the central round tear is actually the anterior hyaloid. It's very clearly visible that the edges of the posterior capsular tear are spindle-shaped and triangular, and these are at risk of running towards the periphery. So the best thing to do is to convert this tear into a posterior capsular rhexis so that I can still have the ability to place the lens into the bag. And I want to do it before doing a vitrectomy, simply because during vitrectomy itself, I could enlarge this irregular posterior capsular tear. So eventually I had to make a second side put, and it would have been worthwhile if I had done this before itself. So I put in OVD so that if at all there is any vitreous, there is pushed back. I don't engage it with my forceps. Since the visualization is quite good because of excellent dilatation of the pupil, I'm very clearly able to visualize the posterior capsule, grasp it, and then initiate the tear into an circular tear and then complete the posterior capsular rhexis. So now I have a posterior capsular tear, which is circular and round with continuous edges, and this is unlikely to run towards the periphery.
Just to pause here, we cannot do the posterior capsular rhexis when the vitreous is prolapsed out. So this is possible only when we are able to push the vitreous back with your viscoelastic, and then you're going to go ahead and do the posterior capsular rhexis. If the vitreous fibers are prolapsing out into the antechamber, your forceps is going to entangle it, and when you're trying to do the rhexis, we're going to induce a lot of traction of the vitreous base, which is contraindicated. So this has to be tried after pushing the vitreous back. So when the vicinity of the forceps, which is tearing the posterior capsule, there should not be any hint of any vitreous. If it is there, then we have to stop it, deal with it, and then do it later on. The reason why I'm emphasizing that if possible, try to do the posterior capsular rhexis before doing vitrectomy is simply because once we do the antivitrectomy, the eye becomes hypotenuse and there's a lot of wrinkling of the posterior capsule, and the posterior capsular rhexis becomes much more difficult to do it after doing the vitrectomy. So preferably try to do it before antivitrectomy, and if you can do that, then there is a lesser chance of extension of tear during antivitrectomy. So that's the idea.
Still feel that there is no vitreous prolapse, and I'm not sure. So I go back, inject diluted triamcinolone acetate, irrigate it, and still I'm not convinced that there is prolapse of the vitreous. But nevertheless, I would want to go ahead and do an antivitrectomy. I also need to clear these small lens debris or lens fibers which are there in the antivitreous. So the irrigation goes in through my left-hand side port, and I'm introducing the cutter through the right-hand side port. And please note that the position of the cutter before I started, it is positioned at below the level of the posterior capsular tear, at the level of this anterior hyaloid which is ruptured. And then the cutting is begun. The irrigation handpiece which is held is directed away from the posterior capsular tear and the cutter is held behind. And I'm using the Alcon Legion Phaco Machines cutter. This is an electric cutter and it does a good job. We can see these little bit folds on the posterior capsular edges of the tear, which might suggest that there could be some vitreous fibers around. Eventually, all of this is cleared in a matter of a couple of minutes. And now with the better visualization, we can see the clear demarcation of the posterior capsular rhexis. The most important message I would like to give is whenever we are suspecting any vitreous prolapse, the vitreous has to be dealt in first before removing the cortex. So that's what I'm doing now with the same cutter. The settings are changed to the cortex mode. I'm using the vitrectomy cutter itself, which is probe facing up. I'm engaging the cortex, stripping it, and then aspirating. The hands are switched. The remaining part of the cortex in the opposite quadrant is also aspirated out. So now we have a clear view. There's hardly any cortex left. We have a nice posterior capsular rhexis. There's no evidence of vitreous in the bag. And now is the time to place the lens. I'm going to use cohesive OVD to deepen the capsular bag and then the originally.
So here another one trick here. If we use HPMC, there is a higher risk of the chamber collapsing, the bag collapsing, and it might be difficult for us to introduce the lens in the bag. So if we use cohesive OVD, which is like sodium hyaluronate, it maintains the space as you open the big wound of the SICS and as we go inside, so that the haptics can be slid under the rhexis and into the capsular bag. Now this is a rigid PMMA
planned PMMA lens is gently negotiated through the antechamber into the capsular bag. The distal haptic goes into the capsular bag first, followed by dialing of the trailing haptic into the capsular bag. I just want to ensure that both the haptics are horizontal and away from the area of the posterior capsular tear. Gently, the lens is dialed to get into a desired position. A 10-0 nylon suture is used to close the main incision. Now with the irrigation and the cutter, I go into the antechamber and the cutter is introduced behind the lens to go and aspirate all the OVD which has been pumped behind the posterior capsule. And once it is done, the OVD in front of the lens is also removed. Diluted triamcinolone acetate is used one more time to rule out any prolapse of a single vitreous fiber, and there seems to be none. Diluted pilocarpine is used, the side ports are hydrated, the conjunctival flap is closed using an atovicral suture, and the intracameral antibiotics are placed into the eye.
So I think I'll move on to my next case. Next case is again a posterior polar cataract. I'm doing SICS. Now this has a bimanual cortex aspiration, like the automated aspiration system.
I'm refilling the chamber both underneath and above the nucleus with HPMC just to ensure that the chamber is maintained throughout. Using the phaco sandwich technique, the nucleus is grasped between the underlying vectus and the overlying dialer and then gently extracted out. As the nucleus is being extracted out, the posterior capsular tear is just staring at me. And as the nucleus comes out, there is also a momentary shallowing of the antechamber. Well, in spite of all the necessary precautions, the posterior capsule is wide open now. So at this point, I don't think the antihyaloid is ruptured yet. So let's find out. I'm trying to refill the chamber with OVD, that's HPMC, injecting from either.
So the reason why I told that, I don't think the antihyaloid is ruptured, when we looked at the shape of the posterior capsular tear, always study the morphology of the posterior capsular tear. When the edges are not very widely splayed open, and the edges are not distorted, that indicates that probably the vitreous is still not prolapsed out. God has not colored the vitreous. There's a reason we can't identify unless and until there is some change in the shape of the collateral structures. That's the only way we can identify the prolapsed vitreous. Now, looking at this morphology of the PC tear, we can see that it is fairly narrow. That's the only hint which I'm having, that probably the hyaloid is still intact. So that's the reason why I'm telling. The next point, when we want to introduce OVD into the chamber, it's very important for us to understand that we cannot push in more OVD in the central part of it. The moment you push more OVD into the central part of it, even if the hyaloid was intact until then, is going to rupture or is going to make the vitreous come out. Trick is you need to introduce the OVD in the peripheral part of the chamber, in this part or in this part, and avoid injecting OVD directly within the capsular tear. That is something which we should be worried about.
Ruptured it, so that's fine. Unusual change in the configuration of the posterior capsular tear, which could suggest a ruptured hyaloid and a vitreous prolapse. So looking at the margins of the posterior capsular tear, which are quite regular, I'm still confident that the antihyaloid is still intact. I want to remove the cortex now. So I decided to go in with the
So the cortex aspiration with the posterior capsule open, the best option or reliable option would always be to do a dry aspiration. The only disadvantage with dry aspiration is that the aspiration tip gets clogged very frequently, and you have to come and flush it off and go again and refill the chamber with OVD, aspirate, and then that's a safe bet. But you can also use with irrigation as well. But the trick here is the flow has to be very, very slow. Like the bottle has to be, hot light has to be very low, so that it is not going to be having a very high turbulence, which can rupture the antihyaloid.
manual IND itself. So one prerequisite which I always ensure in such situations where the PC is open but the antihyaloid is still intact is to decrease the bottle height to significant levels. At this point, I've kept it at around 50 centimeters down from 100 centimeters, and then gently going in with my aspiration cannula to tease out each of these cortical fibers. Now, because the antihyaloid was quite intact, I was pretty much relieved, and there was a momentary lapse of concentration. And instead of putting in OVD before switching hands, I abruptly take out the hand, and there is a shallowing of the chamber. And it was my lucky day. In spite of this momentary shallowing, the antihyaloid continues to be intact, and the cortex from the other end is now being aspirated out.
So again, you can look at the shape of the posterior capsular tear, morphology of the PC tear.
As the last bit
narrow.
of cortex is being removed, this time I'm very mindful of not coming out with the irrigation handpiece. Instead, as is customary, I'm going into the antechamber with my OVD and gently inflating it as the irrigation handpiece is withdrawn, ensuring that there is no chamber fluctuation. As the OVD is being injected, let me pause for a minute here and just show you the edges of the posterior capsular tear. When the posterior capsule is split and the edges are regular, not splayed or not widened in one quadrant or the other, this is a clear indication that the antihyaloid is still intact and there is no vitreous disturbance. So just looking at the edges of the posterior capsular tear can give you some idea of whether the vitreous is prolapsed or not. The planned multiple
Deepak, I think this thing is hung.
I think the commentary is gone.
Network is not there, I think.
His network is unstable, I think.
Okay.
We'll just wait for a minute if he joins back.
We can start the discussion till then.
Yes, sir.
So after this great surgical extravaganza, may I request my co-moderator, Dr. Pankaj Shah, to invite the discussants and take audience questions.
It was wonderful lectures and video presentations. Let's have a discussion on all these presentations. I invite Dr. Ranjit Dhaliwal, sir, to have his comments on today's topics.
I think I'll not have any additional complications to add to what all has been said here. Wonderful. They are all wonderful surgeons since they have encountered all these and tackled all these. I would say the forte of a good surgeon is repeatability, and that is what we should aim to achieve. Every good surgeon is a master at achieving repeatability. This is one thing I would like to say here. I'm not going into the details. Okay. One complication that I have not come across today is, frankly, it's not a complication for SICS surgeons. The implant goes upside down. So we don't have to have all that paraphernalia and all those tactics. We don't have to use anything. We just take out the lens and put it back against the proper side up. I'll be sharing a video at the midterm AIS conference in 2 months' time. And rather, if somebody is seeing that video, he would say, was there a complication there? It appears as if nothing has happened. And I'll take this opportunity to just convey to all this webinar, as all other webinars of ISMS, ICS, and Maharashtra State Chapter have been beamed from YouTube and Facebook. And we have wonderful ISMS, ICS webinars, YouTube channel, and a Facebook page. I would request all to go and subscribe to that channel. See all the videos there. I think there are more than 100 webinars placed there. And I'm working on it. I might seek Deepak Megur's help for that. We might download those webinars, split them into different presentations, and add all those onto the same channel. And the Facebook page too, and you can add your own videos there on that Facebook page, ISMS ICS webinars page. And there's one thing, I don't have experience about it. I heard rather me and Dr. Kiranjeet from Amritsar, we were discussing when in difficult capsule rhexis cases, like you're hearing the Argentine flag sign and all that. So if we puncture the capsule in the middle, that is where the capsule moves the maximum. We are bound to encounter that. And many times in our mature cases, we've been going in for that envelope technique, and we are puncturing the capsule on the edge of it, at the place where the edge of the rhexis comes. And I've not seen it extend. We have to cut it with the corner scissors and to complete the circular rhexis. So Kiran called it the trampoline effect of the anterior capsule. So he's also working on it. Maybe some more people take it up, and we might be able to make the rhexis more easily by going from the mid-periphery or the periphery rather than going into the middle of the capsule. So nothing specific with all these presentations, but I'm a fan of Deepak Megur, and it's so nice to share space with him all over again today. Wonderful. Thanks, Deepak.
Thank you, sir. May I request Dr. Megur, sir, to continue his presentation?
No, I think if you're late by this thing, we can conclude.
You have the whole night, Deepak.
No, it is not like that. Other people are also. I had just the dashboard memory attachment.
Yes, sir, you can show that
video. Please show it.
So DMD is another very common thing which is experienced by the beginners, but often underdiagnosed. So I hope my screen is seen now.
case which has a post-operative corneal edema on the first post-op day. This is operated by a resident doctor, and it is presumed that over a period of time it's going to clear. But on the fourth post-op day, the edema still persisted. So an anti-segment OCT was done, and it showed an area of detachment in the inferior half of the cornea corresponding to the area of corneal edema. And the detachment was quite large, and it deserved attention. The first lesson is, in a non-resolving edema, always get an OCT done. That really, helps us to rule out the descending membrane detachment. Now, the operating surgeon did not have an idea when it happened, so we went back and tried to look at the videos, and it wasn't very conclusive at what stage it happened. The only guess was that during nucleus maneuvering it would have happened, or a second option would be during the side port hydration. So these are the two steps where it was suspected that the descending membrane detachment would have happened. Nevertheless, now we need to manage this. Let me pause the video and spare a moment to discuss about descending membrane detachments. The inferior descending membrane detachments are very difficult to treat, unlike the superior descending membrane detachments, because whenever we use the gas or an air to support the descending membrane detachment, the superior ones get adequate tamponade because the bubble always moves up, and the superior detachments, it's easier for them to tamponade. However, the inferior detachments are difficult because the bubble tends to move up and the inferior part of the area doesn't get the necessary tamponade effect. So preferably whenever we have an inferior detachments, the choice of gas always is either SF6 or C3F8, simply because they stay inside the eye for long, and if we can ensure that the patient lies in a supine position for a prolonged duration of time, the chances of reattachment quickly are quite high compared to just using an air. If it escapes out, again, the chances of redetachments are very high. So inferior detachments are quite tricky, and we need to use the right maneuver. So in this case, I'm planning to have an overfill of the chamber, and to prevent pupillary block, I plan to do an inferior iridectomy. So the surgery is now being done under peribulbar block. Speculum is placed. I'm making a separate fresh side port entry. For mixing the gas to the desired concentration, we're taking 0.7 ml of C3F8 gas, and then we're mixing with air to get the total content in the syringe to 5 ml. So 0.7 ml of gas in the total volume of 5 ml of gas gives rise to a concentration of 14% of C3F8 gas, and that's the concentration which is thought to be isoexpansile, and I'm going to use that concentration here. The cannula is placed well within the antechamber before inflating it. Once I'm certain that the cannula is inside, the gas is injected into the antechamber. And to do an inferior iridectomy, I'm making a stab incision in the at 6 o'clock position. This incision has to be very short. We want to have a very small corneal length here so that we can access the iris very easily. The iris is got hold, a small iridectomy is done, and the incision is closed with suture, and that's it. I'm patching the eye and asking the patient to lie down as much as possible. And the chamber is again refilled with the same gas once again. I just want to maintain the pressure for a little bit more time. After maybe 5 minutes, I let out the air a little bit. And these are the first day post-op pictures, and the inferior cornea is cleared off. We can see the gas bubble size has shrunk. It's about 3/4 fill of the chamber now. Nevertheless, we are going to ask the patient to maintain a supine position for as long as she can have, so that we don't have any redetachments. And these are the OCT pictures. And for a couple of weeks, the gas bubble is decreasing in size, the descending membrane remains attached, and the cornea is clear. To summarize, so video reviews are a great.
I think with that, I'll just conclude my presentation, highlighting the importance of using anti-segment OCT in any case with persistent corneal edema, because descending membrane detachment can be very well treated if identified very early, rather than just sitting upon it and putting hypersol drops. So we may be missing out on some hidden descending detachment. So whenever we have a persistent corneal edema, please get an ASOCT done, even if you don't have access to get it from somewhere else. That is really helps us to manage well, and the outcomes are damn good if you intervene at the right point with the either air or gas. So that's it. Thank you for the opportunity.
You, sir, it's always a pleasure to watch your surgical videos. It's always said that you are not an accomplished surgeon if you're not having any surgical complications. But he who learns from the mistakes is a true surgeon. Thank you so much to all the speakers. And because of want of time, I request the chairpersons to give their brief concluding remarks. I invite Dr. Shakya, sir. Dr. Prakash Marathi, sir.
Hello. Yeah. So I think it was a wonderful webinar. Two talks were basic by Dr. Mihir and Dr. Sonali. And the videos by Dr. Sunil and Dr. Deepak, they were fantastic. I think first two talks were theoretical, but next two talks showed the complications. Their videos were perfect. And not only complications, how to tackle them in the precise way by the experts' opinion and in their hands. It was a fantastic demonstration. So I think it was a wonderful webinar and very nice message given to all the delegates. Definitely they are going to learn about the complications and how they are going to tackle it. Thank you so much.
Thank you, sir. I invite Dr. Anil Shah, sir, for his concluding remarks.
Thank you, sir. It is a wonderful talk. Every surgeon faces a complication. Even a simple surgery can become complicated and you get a stop. So learning complication is actually opportunity for all of us. If we master the complication, then we are always safe. I think today's webinar is a wonderful webinar, and I hope everyone has liked it. And all the speakers have shown various aspects of complication. Thank you very much.
Hello, about Dr. Shakya.
So Shakya is not there.
Yeah, he is there. He's there. Hello, Dr. Shakya, are you there?
He's on. Yes.
I'm audible?
Yes.
Am I audible? Am I audible?
Yes, sir.
Yes, sir.
Really, it's a wonderful webinar. I'm thankful to Maharashtra chapter of MSICS, especially all office bearers, especially Dr. Anil Shah for inviting me for being a part of this webinar. It's a wonderful webinar, and I think this webinar have covered all possible complications which we usually encounter during our surgery, and management part is well covered. Especially I'm thankful to Dr. Deepak. His presentation was excellent. Thank you, sir.
Thank you, sir. It's now time to conclude the session. And I request my co-moderator, Dr. Pankaj, to propose the vote of thanks.
Thank you.
Manish Bappa is not there and Mishra sir is not there.
Yes.
Yeah, Dr. Mishra had to leave for some emergency, and even Dr. Bape sir is also in some emergency. So, but we had a wonderful discussion and a good talk by all the speakers. I thank all the speakers, discussions, chairpersons, and our wonderful audience for being there. And lastly, Intod also for supporting this webinar. Thank you, all of you. Thank you.
Thank you very much.
Thank you.
Thank you, everybody, and good night.
Good night.
Good night. Good night.
Good night. Thank you very much, sir.